Well, all right, everybody. Welcome to the second Medicaid Client Voice Council meeting. I'm Deputy Chief of Community Engagement, Jason Peterson. We are waiting for one more member, but we'll get started. Hopefully, DeAndrea will be here momentarily. 4 of our members could not be here today. They contacted me in advance of the meeting and unfortunately could not join us. But we're thankful for all of you who are here, especially those of you who traveled from great distances. And along those lines, I have some great news for you. The mileage reimbursement, because of the price of gas has been going up, our mileage reimbursement rate has gone up as well. So you will now be reimbursed 52 cents a mile for your visits to the Client Voice Council meetings. You already have a sheet in your packet on the right side. If you open up your folder, you have a sheet in your folder that's already been prepared for you. All you'll need to do is sign it and leave it at the conclusion of this meeting, and that expense will be taken care of for you. So good news for those of you who travel great distances to be here, and we are appreciative, no matter how far you travel, for your service on our council. If you remember at our first meeting, we talked about some rules of engagement. We thought that would be a good place to start this meeting, just kind of finalizing and formalizing the rules of engagement that we're going to use as we discuss issues and matters surrounding Medicaid. So I'm going to invite your chairperson, Allison Caballero, up to the podium, and she's going to so if you go to page 5 in your packet, page 5 of your charter, your Client Voice Council charter, you'll find the rules of engagement. So let's go to page 5 and just discuss that, make sure we're all in agreement, maybe take a vote to formalize that, and then we'll move on to our first guest speaker.
Awesome. Thank you, Jason, and for that great news. And again, welcome to everyone, including our DHS friends and invited guests. So on page 5, you'll see those rules of engagement. Remember, after lunch last time, we kind of talked about how we wanted to function as a group. And these were the things that we said. I'll kind of paraphrase these and you can follow along. But essentially, that in order to be respectful and to be efficient, those were the things we said we wanted to be during our time together. And these bulleted items were the specifics that we think will get us there. So allowing each presenter to go ahead and finish their presentation, knowing that at the end there will be time for questions. We may have guests from time to time that invite us to ask questions along the way, but when they don't, we'll just assume that they should finish their planned remarks and then we'll have an opportunity for questions. We're going to allow other council members to complete comments without an interruption, but at the same time, we're going to try to keep those comments brief because there are so many of us and we want to allow our guests time to respond as well. So you may hear myself or Jason jump in sometimes and ask that we move along to the next comment just to keep things moving. And then, of course, we want to stay positive and supportive. We all have a different experience as Medicaid clients and family members, and so all of those are valuable. If they just wanted one, they would have just invited one of you to be here, but they invited us all, so we want to be mindful that we may have some differences of opinion and just be respectful about those. We said that to do our jobs here, we have to be open and honest and maybe be willing to share things that are tough to talk about or may not be exciting or may not be music to someone else's ears, but we're going to speak openly and honestly in this effort of ours to be helpful about the, 1 in 3 Arkansans that are served by Medicaid? So that's a lot of folks that we have the potential to help. So we also want to make sure that when we provide comments that we be clear whether or not those are facts or they are opinion. So anything that kind of comes across sounding like a fact, just be sure that it is indeed a fact and that you would have some kind of source to back that up if needed. But opinions are equally welcome. And then just to keep us from speaking over each other, if you would just raise your hand whenever you do need to speak, and whoever has the podium can call on you at that time and recognize you, and that'll help our listeners and watchers from home as well be able to hear everything that's said in the room. And then we also said we would primarily use email. So how'd that go for everybody this last go around? I'll be honest, I was slow to kind of get with the program on that. I had to set a reminder on my calendar to check that email. So if you struggled with that, maybe you want to set a reminder for yourself as well. So we are going to have some work under expectations. I don't think we need to go into any of that. I think just those rules of engagement. Did that capture what you all discussed, what you feel like we all discussed the last time we met? Okay. So we had also talked about whether or not, one second, Jerry, whether or not we wanted to adopt something called Robert's Rules of Order. And I've given that a lot of thought, and my recommendation would be that since primarily we won't be a voting body, that might be a little bit too formal for us, and that as long as we can stick with these kind of rules of engagement that we've outlined for ourselves here, we should be able to stay on track and be productive. So, Jerry, what were you going to add?
On the Microsoft Office.
Oh, right, we were waiting on the mics. Thank you, Jason.
Oh, I'm sorry.
Yes, on the Microsoft Outlook email.
Office. Okay. On the Microsoft Office communications, we have Outlook, but we don't have anything else. We have no way of sharing files. We don't have Word or Excel or PowerPoint or anything to collaborate with.
Okay, so yeah, the
So-
Word and Excel and PowerPoint would have to be installed on your computer. But I don't know if you don't have those installed, if you would be able to
Microsoft
view the
has
attachments.
virtual tool also, Office 365, which you don't need to install it on your computer. You know, as long as you pay for the service, it's virtual. Same
Okay.
as Outlook, you know.
So are you requesting that DHS look into adding some kind of file repository, or?
Yeah, adding the shared file component under the Microsoft Virtual, so we could share and collaborate on files.
Jason, is that something? Thank you for short people. Appreciate it.
But I'm sure I can find someone who can answer that.
Yeah.
We can look into that and try to make that happen.
Yes,
Shouldn't cost that
Cassandra.
much. It's a very powerful tool.
Oh, yes. No, thank you.
I was gonna say that I guess we could look into, or setting up on the back end, maybe something via Google Docs. I know that's something that we used in school and it's free. So, but it has that same type of collaboration where multiple people can work in a document or a PowerPoint or Excel sheet, but it's completely free through Google. So I don't know. I'm just throwing that suggestion out there.
Thank you. All right, moving over to Frank.
Along those lines, if you I know at least for Windows PCs, there's LibreOffice and there's OpenOffice, which are free Office suites as well.
Awesome. Okay, well, we'll make note and take that back to the DHS and maybe AFMC logistics team and see if there are any resources for shared files that we can look into. And in the interim, if you get a file that you can't open, if you will just reply back to Jason or whoever sent that and let them know that you can't open that, we can make other arrangements to get that to
So
you.
was everyone able to open the newsletter that I sent out? Everyone is able to look at that? Okay, so this is more anticipating a future need. Is that correct?
Yes. Right now, we have no ability to collaborate.
Right. The need hasn't arisen yet, but we're anticipating that it will. So we'll.
Gotcha.
We sent out the document for rules of engagement. We have no way of contributing our input to it, you know, without creating a separate file. And so
Gotcha.
if one person does some editing on it, then
Okay. And
somebody
for
else
those of us
can't
working
contribute.
collaboratively on agendas and
Right.
that Google file might be advantageous. Perfect. Okay. Any other thoughts about the rules of engagement? Any objections to adopting those just like they're written? Hearing none, we will consider those the way we want to live with each other. So I'll turn it back over to Jason to introduce our guests, and I'm going to go have a seat over there.
Thank you, Allison.
Thanks.
So we have a couple of guest speakers today to talk on some topics that are in our near future as Medicaid recipients or as DHS. But we have a whole lot of folks here, just like we did at our first meeting, including Secretary Gillespie, a lot of the division leaders. This is, again, just to show you as council members how integral and important DHS considers your work and the advice and the feedback that you're going to provide. And so they are here to listen to the questions that you ask, to hear the presentations that are made, and to be available to answer questions should they arise in their area of expertise. So I want to thank all of you guys for being here today and being a part of the council. Our first speaker will be Melissa Singleton. She's director of DDS, that's the Division of Disability Services. She wants to share about proposed changes to the Community and Employment Supports Waiver. She has a PowerPoint she'll share with you, and she wants your feedback and your questions about those proposed changes. So, Melissa?
Hi, good morning. Thanks so much, Jason. So, fun fact, so Singleton's my maiden name, and Stone is my ex-husband's name, and Weatherton is my new name. And I'm starting to get a complex. But DHS graciously gave me emails for all of them. So, since I seem to have a lot of aliases. All right. Let me get my clicker. So as you guys might have remembered from last time, or many of y'all already have worked with me in the past, DDS oversees two waiver programs. And a waiver is really just a federal vehicle that allows you to target a certain population with a certain set of services that are not available to regular Medicaid recipients. And so today we're going to talk about, I think, our big waiver that's referred to a lot of times as the DDS waiver. And it's actually called the Community and Employment Supports waiver. And waivers, well, this particular waiver runs for 5 years, and each one's a little different. And right now, we had just put a new one in place so that we could start our 5-year clock, and this is an amendment. So they like us to do major changes after we get that 5-year waiver in place. And so you'll see on this version, it's out for public comment right now, and I'll explain to you how you can send in comments if you don't want to speak up today, but we are accepting comments, and we would like to hear them from y'all. So just a little bit about this particular waiver. This waiver allows children and adults to remain in their homes and communities rather than living in an institution. So for those of you familiar with intermediate care facilities, they're private intermediate care facilities and then state-run ICFs, which actually is under DDS. And that's where people with intellectual disability can live 24 hours a day. Well, those clients who meet the exact same criteria have a choice. If they do not want to live at a facility, they have a choice to receive the same level of service in their home through this waiver. Clients, to be eligible for the waiver, have one of our qualifying diagnoses of autism, cerebral palsy, spina bifida, epilepsy, Down syndrome, or a general, likewise, intellectual disability. And then currently, like I said, it's a large waiver. We're serving around 5,400 children and adults at any given moment. And right now it costs approximately $300 million a year to fund the waiver. We, though, as many of y'all might have seen, and we're so excited about this, the governor back in December announced, this has been one of his big initiatives since he's been in office, as well as Cindy's. And the governor was able to announce back in December that he would like to secure funding to serve the people who were on the wait list as of December. So to clear the wait list as it stood. So he announced that we would be eliminating the wait list, which is about 3,200 people in December, and we have a goal and a timeline to do that over the next 3 years. So not only are we adding those slots, but for many of you that are familiar with this waiver, we have specific slots set aside for children who come into foster care who also meet the criteria. So we will be adding, in addition to the 3,000, we'll be adding 200 slots specifically for children who come into care because it has been proven that it's much easier for children to return home back to reunify with their families once they have this type of support. And then in the alternative, if they can't return home, this betters their chance of being adopted if the adoptive family knows that they're going to have assistance with their disability needs. So we're adding some new services to the waiver. And I'm going to briefly touch on them. And I'd like to start with the second one. So we're adding a service called Enabling Technology. Now, we're a little behind the trend here in Arkansas in the DD world for enabling technology. There's a lot of states across the nation who have some pretty robust programs and have shown some real results. And in fact, I saw a very cool video a couple of weeks ago where a client was at work, and rather than having a worker or direct support professional with them at their job site, they were able to communicate and get direction from their worker through an earpiece and a watch. And so they were able to ask their direct service worker questions and feel that independence and still feel supported by that work. So they also have, in the video, they had a vignette where clients had a automated prescription machine. So each day, the machine would dispense the medication so that the client could live in their home and get their medication at a certain time each day independently and take their pills. So we think that those are just two examples of so many things you can do with enabling technology. But we do believe that by enhancing the service, adding it, and highlighting it in our waiver, that we can help clients be more independent and less dependent on someone being there all the time. Now, I will say I've already received some calls from some moms on enabling technology, very fearful that we are some way attempting to not provide direct care in lieu of technology, and that is not the goal. And in fact, we are going to do work groups to build out this service and have parent input in this process. It is not meant to take the place of a direct service worker if that person needs that type of support. It is a choice. And so we will be building this out with probably a new provider type and new codes, and those work groups will begin once the waiver is approved. Let's go back to the top real quick. So the service of HCBS supervision and monitoring, this is a brand new service. So as you can imagine, under our waiver, we have a number one service. It's called supported living. And probably 96% of our cost goes towards supported living. And supported living is a training service, meaning it's not personal care. Personal care does more helping with bathing and using the restroom and things of that nature. Supported living is intended to help clients with disabilities integrate into their community and gain independent skills. So I have been noticing for years, I shop at the Hillcrest Kroger, there is a lot of clients in there, which I didn't even notice until I started this job, that are in there with someone that's helping them grocery shop. They are billing supported living, likely under this waiver program. So workers can take you out to the grocery store. They can teach you how to set up checking accounts, count money. It can be even taking people to the movies and interacting with people out in the community. But it is a training exercise. And so we did not have a service for just if someone needs someone at their home to just monitor, right? So we have a lot of clients who really, it's not safe to leave them alone for various reasons. And so if someone needs to stay there while they're asleep, someone might need to stay there, and they're just going to hang out. They don't want to train on anything, right? And so now we're going to have this supervisionary monitoring service, which is different, and there's not a training requirement to that service. Going down to increasing group home capacity. So this is a hot topic. I'm either going to get people that like it or really don't like it. So right now, there is a restriction that people on the waiver cannot live in a setting with more than 4 people. And so that has been in place since 1995. I have gone in and asked that number be raised from 4 to 8, and here is why. So at DDS and at DHS, we really believe people should have a choice of where they want to live. They should have a true choice of if they want to stay in the community. Some families are much more comfortable with their loved one living in a more secure 24-hour setting. But but we have, and I think it's been some of it amplified due to COVID. We have some clients with some pretty significant behavior needs that need support, that need a high level of supervision. And right now, we are having a hard time. As you can imagine, those clients have a very hard time in apartments, oftentimes with one-on-one staff for various reasons. So, and they have a hard time finding staff that want to be that person's direct service worker because they have outbursts, because they have behavioral issues, because they could take off running, right, in some cases. And so we have a hard time with that. We have seen that we have a better, stable living situation oftentimes when clients can live together if they actually have a peer group and there's multiple staff. And in these group home settings, there is often at least 3 staff at any given time. And so we are looking at raising this for some of those clients that really need that type of support, that really need more than 1 staff member around, probably need 3. And so this is what's being asked. And like I said, we'll either get some good we'll either have supported this or not, and I understand both sides of it. But we are trying to put a quick measure in place to help give a very distinct group of clients an appropriate place to live and receive service. Now this one y'all should really like. This is much more fun. So we are very aware that we are having a workforce shortage, right? We are doing all kinds of things to assist you guys. We have been, we just put out a very large amount of money under the American Rescue Plan Act that can go to providers to help recruit staff. They can give up to $1,000 hiring bonuses and retain staff, so they can give a large amount of money to those staff over the next 24 months. And so, in fact, $112 million went out in March, and we were so excited about it. So, and it went to clients that have providers who are in the aging space, the behavioral health space, the IDD space, and to personal care and assisted living providers. So it went to a large group of our providers. And we did that in an attempt to try to recruit and stabilize this very low workforce, because we're all clamoring sometimes over the exact same type of employee. And I'm trying to hire those same people at our 5 human development centers. It's all the same types of people, so and credentials. So we do not think that we're there yet, and we need to open it up for lots of reasons. We need to open it because we're about to add 3,000 more people to this waiver, right? Who really need service and need staff. So we've gone in on this version, and we have marked to allow legal guardians. We've marked to allow family, which could be a parent of a child. And we've marked provider, and then we've also marked legally authorized person. So we've marked them all, okay, on the direct care services. Now, that does not mean that this is a self-direction program. We've not marked that. This means that those family members can go work for an enrolled Medicaid provider and be hired and paid through that provider and meet the same requirements. You need to go ahead. We're going to have to do the training and the background checks and all of that. But before, it was restricted where family in certain situations could not be workforce no matter what. So this is actually really going to open it up. And we hope that it allows our clients to receive quicker and better service. All right. I got worked up on that one and didn't realize I'd gotten through the slide. This is the boring slide. So this is technical clarifications. So we've gone in and just made, like we do all the time, you find things that you're like, why does that say that? So we've gone in and just clarified different pieces of the waiver. We had written the original waiver before this program went into the past program. So a lot of things were just missed, and we've gone in and clarified who's on first, who does this, what does the PASS do, what does DDS do, what does the provider do. We've also gone in and tried to remove restrictions. We've had some really restrictive language underneath some of our services, and that was, again, prior to it going under the PASS program, and it was being managed under the DDS office. And so in order, I think, to regain some, keep control and consistency, we made things very prescriptive. Like you could only get respite at certain places, really? And so we've gone in and eliminated all of that prescriptive language. So to try to open up respite in particular, and then also supported employment. For any of you who have been to the Blue Umbrella, which I'll promote the store for a second, it's a small little store made out of glass. And when we first started having clients work in the store, they had a job coach with them. And y'all, it was tight in there. So you could have a client and a job coach and our person who works there that works at DDS, and then maybe 2 customers, and you were like on top of each other. And so, we reached out and said, I don't think we need a job coach, with Medrick. I think we got it, right? I think our staff can help him meet his needs and teach him skills. And so, but the service was so prescriptive that we had such a hard time. And it says, no, it says you're going to have a job coach. And once they graduate from a job coach, then they're going to do this. And, everybody doesn't work like that. Everybody doesn't need all the same things. So we've gone in and removed it and made it very more individualized. Oh, good. See, that was it. That's painless. Questions? Yes.
You mentioned the supported living is mainly intended to train you to get up to speed independently. What about those that are doing okay mostly independently, but say may need help transportation wise? Because it can get crazy out there driving in Little Rock, and some people may be okay independent wise as far as living around the house, but then have sensory issues driving.
No, that's a really good question, Frank. And go ahead.
So I was wondering why not have a dedicated, perhaps supplemental HCBS transportation service for someone who may just need their weekly or bi-weekly or whatever the 2 times a week, whatever routine or doctor's appointments and grocery stores, and then you'd have employers a lot of them have commuter FSAs where you get a debit card and you can use them for Lyft and Uber and things like that. Why not have something like that as
Yeah. I think that's a great idea. We hadn't thought about, doing an Uber or a Lyft type card, but you can get transportation under supported living. So your provider can send someone to come get you and take you places and bill under supported living right now. But we hadn't looked at other options. I think that's good because maybe everybody doesn't want somebody with them. Yeah. I'll look at it. That's a great idea.
All right, I'll pass it to you next. So under the monitoring, I love that, but also notice that it said for adults. And I'm just throwing this out there as a parent of a teenager who, at 14, almost 15, I should be able to let her go outside and play with her friends on her own, but I cannot because of her disability. Can't leave her at home while I run to the grocery store either. So just as you all develop plans for monitoring, I think, we should think about who should potentially be able to stay home alone but can't, as opposed to limiting that to adults, because some older kids should be able to as well. And then I had a question about the increase from 4 to 8 in the group homes. What are the objections to that? I'm just curious what people are objecting about, and see if this group might have any guidance on how to help calm any fears.
So I think that from my own perspective, my own research, I think historically there has been a history of neglect when you put disabled clients into a congregate living situation. And, I think that same fear occurs even when people live in intermediate care facility, that living separated is healthier and safer for clients. And I think, from my personal perspective, I think it depends on the client, and it depends on the needs, and it depends on the family. And so just trying to open that up so that it is a choice that families can choose if they want to.
Hey, I have a question. Okay, so I know you guys have proposed some initiatives to address the workforce shortage, and I know that in talking to one of our organization's partners in disability advocacy, that they're worried about this being a wait list to another wait list because of the lack of support staff. So I guess when you look at sustainability, I know that having a family member be able to be your support staff is one option, but what other efforts are you looking at in order to decrease that workforce shortage, to make sure people are able to actually get the supports once removed from the DDS waitlist?
Yeah. I think that's a really good question, and it's something I talked about a couple of months ago, and I work with partners Karen Burnett and Diana, and I think they called, and we actually talked about that as well. So I think that would be the worst case scenario, right? That people wait 10 years for a waiver slot. We give you a waiver slot, and then there's no one to serve you. It's almost worse in my mind, right? To be that excited. So, no, we are watching that. We will be releasing slots on a monthly basis. We are adding some language. We're negotiating right now, but we're adding some timeliness into our contract with our passes, because we do expect service to be done timely. And that timeliness also means a timeliness standard from when we release a waiver slot to when a client receives service. So we think that in conjunction with trying to do the payments for retention, opening it up to more workforce, and holding the passes more accountable for timeliness will assist with that. But we're also been engaged in a task force over at the legislature where they are looking at different options for a certification for this workforce, so that the so that the worker, based on their level of certification, can be paid at differentials. And so, and of course, that would be up to the passes would be doing the payment mechanism, but, formally recognizing that this is a career ladder, and that based on training, that a person's time is worth more. So I think we have a couple, different things coming out at different angles, but I wouldn't be truthful to say that it is a fear of ours, that we want these clients to get service, and we want them to get the service in the next 3 years. So we're carefully watching it.
Yeah. And then building on my previous comment about the dedicated transportation thing, or another way you could do that one would be like the staff would just take you to the grocery store and stuff, and then maybe and then have them be on, instead of just cutting their hours, let's say they're with you 20 hours a week, and then you spend 8 of that out and about, so that's 12 hours that you could just have the 8 hours out and about, and then they could still be on call for the other 12 hours to help with other clients as needed.
No, Frank, I think that's a great idea, and I think that a lot of clients would like that, right? Not having someone with them all the time. And I think that that's what we need to work on building out under that enabling technology service, because I think there's ways that we can stay connected in case someone needs help quickly, but still not have someone trailing them all the time if they don't want them.
Hi. I was wondering what happens to the people that weren't on the list at the cutoff date, because I'm assuming every day those waiver applications are coming in. So what's for the other people?
That's a really good question. So right now, we've not tipped that number. So what we did back in December when the governor made an announcement, we filed an emergency COVID vehicle. Who knew? With the federal government, and added 200 slots that very day. That's what we filed. And so our number is actually lower at this point. But you're right. That's why we're careful not to say we're eliminating the wait list, because I don't think you can ever eliminate the wait list. We have people sign up every day. But our goal is to get them on service quicker. So if we can clear the list as it stood with 3,000 people, we hope to not get back to the point where people are waiting 10, 11, 12 years for the service and let it build to that type of capacity.
What was the total number of slots you had for the last 5 years, each year? And how many applicants have you had for those slots in each year? Mm-hmm. And how many people have been denied and accepted and put it on a waiting list, or accepted and put into the program?
Yeah, that's a great question. Now, and I can send you the exact numbers, but I'll say this. The governor redirected tobacco settlement funds back in 2017. And I was able to add 500 slots. And then when we set the PASS program up, they pay a premium tax as an insurance company doing business in the state of Arkansas. And the law says that the part of the premium tax goes towards the wait list. So we were able to add 700 more slots in January of 2020. And then, oh goodness, it's all blending together. And now we're doing the largest slot reduction ever of this 3,200. But I'll say that until we get large amounts of slots released, like we did with tobacco and PASS premium, we're not able to add anyone on except for about 100 people a year based on attrition, based on people passing away or moving out of state, and then able to put people on that way. So these slots are a game changer for us. Total slots, so right now we have 5,400, and I'm thinking I have to pull it, but it's around 8,000 when we get finished. We hover on average around 3,200, 3,300 people on the wait list at any given moment. Well, that's a good question. Let me explain it. So if you apply for the waiver, it's a two-part application, and you turn in your medical information to show that you have a qualifying diagnosis and meet the medical requirement. And if you do that for us, we put you on the wait list, because unfortunately up until this point I've not had a lot of slots to give out, and so we just say you've met the criteria, you are number such and such on the wait list. Does that make sense? And once I give someone a slot, we'll go back and rerun it again and rerun the financials and actually give you a waiver slot. I'd have to go back and look, but our wait list is always around 3,000. So, but I can go back and see. Right. We have very few people denied. I'll say that. I'd have to go back and look. It would be on two hands, because you know that you have that qualifying diagnosis. And so we work with you while you're filling out the application. But I'll go back and look to see if we've been tracking. I bet I could do a point in time each year to show how many people had applied and were on the wait list over the last probably 6-7 years.
From Nathan, one from Reba, and then we're going to go on to our next speaker. Nathan.
So I don't mean to circle back, but I had a question about the whole transportation issue, because you had mentioned that there are ways for people on services to get transportation. The only two things I'm aware of are the public transit bus and a private company that will transport me wherever I need to go. And obviously, as you can tell, those both come out of my pocket. So if there are other things available to us, somebody needs to make that available, because I had no idea. And I'm pretty in the loop when it comes to things like that.
No, that's a good point. So I would say under the community employment support waiver, you can get transportation from your direct service worker and bill it under supported living. But
so you mean if it trips you in their car? Is that what you mean?
Yes.
But then
There is,
that's
yeah.
what I was referring to.
You're referring to net, yeah.
Yeah. But for those who don't know, that's just $25 anywhere in the city one way. It's
Net, did you say net is $25?
NATS, NATS.
Nats.
Yes.
Oh, gotcha. A private, okay, all right. Do you ever use the Medicaid non-emergency vans?
See,
NET, non-emergency transportation?
the only one I'm aware of is what is it now? Southeast Trans.
Yeah, Southeast Trans.
They only do medical appointments.
That's true. To and from a medical appointment. And I bet you're having a hard time being in your wheelchair, not being transported by
Right,
a
because
worker. Okay.
I have my own vehicle, but what do I do when that breaks out? You know, how do I get from A to B?
Okay, we need to talk about that. Because you're right. Because the way that it works right now is that you're transported in your direct service worker's vehicle. So if it's not wheelchair accessible.
But no, yeah.
Yeah. Hey, I did want to tell you, you reminded me. Do you remember last meeting you talked about having someone at the hospital with you?
Yes.
We added that back in.
Yes.
Okay. Yeah, and I forgot. That's a big deal. We should have had that on the PowerPoint.
I just want to say that I'm from two sides. We have 3 children now that will require DDS waiver. I have a 6, 5, and 2-year-old, okay? And I have many older children as well. And one of my older daughters works for a company that services an individual that is on the waiver program. She has worked for this individual for 5 years, has never once received a pay raise, and could go to McDonald's and make more money.
I agree. And this has been a real hot topic, and I will be very short because I know my time is up. So when we switched over to the PASS program, the passes are paid a per member per month payment each month prospectively. And I think there's a misconception that we've told the passes or the providers that supported living is worth X amount of money. That's not how the rates are set. The rates are set based on large categories of services. And so I think the passes are hearing that message the more meetings we're having. And I've been real upfront with them on when we add timeliness standards to the contracts around our clients, then I think we will see some different actions taken by the passes because they will need to have the workforce there if they have to meet certain timeframes for a service. So I think we'll see some movement there. But I do want to be really clear that we don't set hourly rates for supported living. The passes negotiate contracts with providers for what they pay them.
That's probably one of the reasons why there is such a shortage, because I can't tell you monthly, she's thinking about, oh, well, I could go over here, as she's struggling to pay her car payment or to pay her bills, they have an attachment to the client and they want to be there for the client, but then these individuals also have to live.
I agree. Thank you all for your time and your attention. And if you have questions, you can email me at melissa.stone, melissa.weatherton. We can get you all of them, okay? Thank you all.
Thank you, Melissa. If I just read my own notes, I would have identified you correctly. I don't know why, but all right. So our second presentation today, we have DHS Deputy Director of State Health and Medicaid, Dawn Steele, who, along with Amy Webb, if she needs help, Amy's here, with the Medicaid Control Center, wants to update the council on the wind down of the public health emergency. There was to be a big announcement yesterday. It wasn't made in a big way, but we believe the public health wind down, the public health emergency is going to be continued. They want to share with you some information on when that inevitably ends, what we're doing as an agency to prepare to have that as minimal impact on those we serve as possible. So if I could invite Dawn and Amy to make that presentation.
A little shorter than Jason, so I'm going to move this around, and Melissa for that matter. And much like Melissa, I'm also going to make my disclaimer. My email, I don't think is up here at the end. I haven't seen the last version of the slides. But my last name is Staley. Thank you, Jason. Not Steele. But I will answer to either. But if you are emailing or seeing it, just to make sure that there is an E at the end, as my husband often reminds me. So with that, we are super excited that you are here. And I'm actually sad about having to cut off the discussion because it was such a wonderful, rich discussion about the waiver, and just makes me excited to also dig in around the public health emergency and what we want to talk with y'all about today. As Jason said, we were expecting a big announcement yesterday that has not come. We're still maybe thinking we might hear something today. I know we've got a call with the federal Medicaid officials this afternoon to hopefully get some more information with regard to the public health emergency and when that might end. Now, that probably means a lot of different things to a lot of different people around. What does that mean? For us here in Arkansas, but also for a lot of other states, that means a few things, and we're going to talk about what that means here today. But also, really want to get your thoughts and feedback on how best we go about that process. You probably hear people talk about things like unwinding or ending the public health emergency or transitioning. Lots of words that can mean very different things, and so we really want to talk with you today about what that means for Arkansas and how we're proposing to handle that process, because at the end of the day, it is a process, both from a client perspective as well as providers, as well as virtually everyone else that is somehow involved with or impacted by the Medicaid program, because what you're going to see in here today is a lot when you think about the last two and a half years in terms of since we've been in the pandemic. There's been a lot of changes. Some of those have been good. Some of those have been not so good. Many of the things that you're going to hear about today are things that we see that there's some good things that have come out of it, and we want to be able to talk about how we're going to continue some of those things. But we know that in doing that, communication and how we do those things is going to be vitally important. And so we really, really encourage you as we go through the presentation today. We want to hear your questions. We want to hear your thoughts and feedback. Y'all are actually the first audience that is getting a chance to walk through this with us. So I'm going to kick it off, and then as we go through, bring up other folks to kind of talk about some of the specific areas that are involved in the public health emergency. And of course, I do also want to take a moment and thank Amy as well as Gavin, who is here with us. I think for folks who may not know, Amy had previously served as Gavin as our communications director. Gavin is in that position. Doing an excellent job. Amy has moved over into a role that is helping us work on a number of initiatives, but one of those is helping us provide significant coordination and facilitation around the public health emergency, in addition to several other things that we have going on within Medicaid that we'll be excited to talk with you all about at future meetings, certainly as it relates to some of our behavioral health efforts, as well as some other things within Medicaid. So with that, does everyone have a copy of the slides? We'll also have them up here, but just want to make sure everyone's got a copy of those. And the clicker. Melissa, did you take the... Oh, there it is. I got it. No, I got it. I'm good.
It's my purse.
Just got to make sure she doesn't walk out with it. All right. So we've talked about this a little bit, but just as a reminder, in March of 2020, which in some respects seems like just a minute ago, but in many others, many years ago, then President Donald Trump signed into law basically the Families Federal First Coronavirus Response Act, or FCRA for short. But basically what that means is it put in place the public health emergency, allowing states to be able to have flexibility with regard to how we operate the Medicaid program, and with that, some additional federal funds to be able to keep people covered, but also to offer different ways of providing services. One of those that many of you have probably heard or participated in is actually a lot of services were able to be provided through telemedicine, which is one of those things that we are planning on keeping across many of our programs. Today, you're going to hear mostly about the eligibility and enrollment aspect of that. At a future meeting, I think we'd love to come and talk with you as well about kind of the provider-facing piece of that and what we're doing around those efforts with regard to the unwinding of the public health emergency. With regard to eligibility and enrollment, really during these past 2 years, one of the flexibilities has been that states are able to do different things, but as part of that, that anyone who has applied for Medicaid or who was previously on Medicaid during that period, going back to March 18th of 2020, continues to stay on Medicaid with a few exceptions. As you can see, only in the case of somebody who has moved out of state, somebody who has died, somebody who requests their coverage to end, or who is incarcerated. Otherwise, and we'll show you some numbers here in a minute, otherwise all of those individuals have continued to be served through the Medicaid program since March 18th of 2020. And this just shows you a little bit as you look at the time frame over those past couple years, really going back to January of 2020, we have added, so this was, since that time frame, we've added a little over 170,000 individuals to the program, which is about a 19% increase in overall enrollment. And you can see this slide just kind of provides a breakdown of what that looks like with regard to our children versus adults in the program, as well as our home, which is our Medicaid expansion program. As we've been through this process over the last couple years, we have continued to process eligibility, to make changes, update coverage, as people have had changes, whether it's changes in life, such as marriages, or if it's changes, with regard to new babies, or if it's changes in income, or whatever it is, we have continued to process those throughout the public health emergency. And so as a result of that, we have been able to actually then identify the clients who otherwise would have lost coverage during the public health emergency, but have continued to receive services through Medicaid. And I think that's definitely, a big shout out to Mary and her team that we have been able to continue doing that and largely operating the eligibility aspect of the program as many other states did not. And I think that has definitely created some challenges for them as well as some of the clients. So we're grateful that we were able to continue doing that here in Arkansas. So as you can see, as of May 9th, 2022, which is the latest data we have available, we had about 300,000 clients that actually had their coverage extended because of the public health emergency that otherwise would have moved off of the Medicaid program due to a change within their household, whether it's income or because we didn't hear from them or they've moved and didn't notify us. And so as you can see, there's a number of different reasons why somebody might have been extended. We've touched on a couple of those. But the other one that we see, and I think this is one that you're going to hear a little bit more about in a minute, is that sometimes people have changes within their level of care, right, with regard to the amount of services or supports that they need, or that they've aged out of eligibility. So we're going to talk a little bit more about both of those particular transitions, but just wanted to kind of highlight that those are some of the overall reasons that we see why individuals have likely, had to continue coverage during the public health emergency. So again, we don't know when the public health emergency will be ended by the federal government, but we are preparing because we know, like with anything else, the more prepared that we can be, the better able we will be to actually implement and be able to do it as smoothly as possible. So currently, the federal public health emergency is scheduled to end on July 15th, 2020, which means that the requirement that we continue to cover individuals who might no longer be eligible would end on July 31st. Since we did not get an announcement yesterday that we were expecting from the federal government, it is likely that will be extended beyond July 15th, but we don't know what that date is. We will hopefully find out more information later today, and once we do, we'll definitely share that information, but this is based on the most current information we have. And as part of that, the federal government has promised that they will let states know at least 60 days in advance when they plan to end the public health emergency. And so we'll, again, have more information on that hopefully later today. When that does happen, that means that we can continue our operations, but also means that for those 300,000 individuals who have been otherwise determined not eligible, that we can go back and reach out and say, hey, we need to hear from you. We need to know what kind of change there's been, if there's been a change in income, a change in your household, so we can process that and see if they are still able to continue receiving coverage. That's a lot of what you're going to hear about today. Is we know that a lot can happen, over the course of 2 years. People move. Sometimes people change phone numbers. People get new jobs. People lose jobs. Lots of things can happen. And so part of what we're trying to do is figure out as much as we can about how we can get that information, update that eligibility file, and then be able to actually determine if individuals are able to stay on the Medicaid program. So, and then one final note, in the last bullet, you'll see Act 780 of 2021 that was passed by the legislature actually then requires the department to complete all of these redeterminations, or basically for those individuals who have been extended during the public health emergency within 180 days of the emergency ending. So as we go through and talk about the program-specific details of how we are planning to approach the transition, just want to make sure that folks have that in mind, that that's something we need to be able to do within those first 6 months of the end of the emergency. This next slide, I won't go through it in detail. You've got it in your packet, but just to kind of give everyone a glimpse at kind of when we look at the population that has been extended during the public health emergency, kind of how that breaks out across the different client types and groups that we have in Medicaid. The top two kind of trade places month to month in terms of the Our Home being the Medicaid expansion program, and then our Kids A and B program. Kind of month to month, they trade places with regard to which one has the most number of clients who have been extended. But as you can see, as of earlier this month, Our Home did have around 82,000, and then Our Kids around 80,000. And then you can see, some of the other bigger categories that are within the Medicaid program and how that breaks out. All right, and so this section of our discussion today really gets into how we are planning to approach the transition, starting with the enhanced outreach. And I'm going to go through this and kind of hit on some of the high points, but really want to make sure we have enough time to hear from the different, what we call kind of our population owners, right? The folks who are here to help us talk about how we are planning to approach the transition, and really looking for feedback from all of you about what are we missing, what we need to clarify, and what else we may need to do. So within the enhanced outreach bucket, just to touch on a couple of these, we actually have started this process now of doing outbound calls, but also receiving inbound calls to individuals who have been extended during the unwinding process. We actually have our partners here at the Arkansas Foundation for Medical Care that are helping us in that effort, so we appreciate their assistance. And that's something, if you know of somebody who needs to update their information, whether it's their address or whatever it is, that's a lot of what we're trying to focus on, is just say, hey, we've looked in the system, we show that, we still have this information on you. Is that correct? If it is, great. If it's not, we want to get that updated, so that way we have the most up-to-date information when we start doing those that renewal and redetermination process. The next one is, I think, trying to really help make sure folks know that certainly happy to call in. You can also do it online. You could do it in person, as well as a number of other communications initiatives that we have been trying to do to make sure folks know about what's happening with the public health emergency, but also how they can help update their information. I know actually I had shared with our federal Medicaid partners recently, our team had come up with a little bit of a fun graphic for May the 4th that was focused on Star Wars. So I think at least we got some attention out of it. So certainly any ideas that y'all have too, we are always excited about trying new things within the area of communications in particular. Within the next bucket, a little bit more about some of our enhanced client outreach. You're going to hear from folks today with regard to the different waiver programs, as well as some of our other programs with regard to how we're planning on doing some of that outreach. A big part of that's going to be working directly with the providers as well. We've got some ideas about how we think that can be most helpful, but obviously want to hear from y'all as well with regard to, if there's thoughts that you may have, reaching out to individual providers with regard to their specific clients, but also working with associations and other groups in the state that can help us get that message out, but also hopefully get that information back to us. And then for those members that are enrolled through our PASS program or through our home, we'll be working with our qualified health plans and passes to also update that information and provide that outreach through the transition. And then this just talks a little bit about some of our enhanced operations that we have, some of which we've already put in place, but then others that we are planning to continue to enhance during the transition. Just to touch on a couple of these, some of the things that we have done is we have actually increased our staffing within our eligibility team, going from 93 to 200 positions that are assigned to specifically work our long-term service and supports cases, and for that means a lot of those programs, which many of you participate in, as well as some of your loved ones, in addition to a lot of the folks you saw on that fifth slide, I believe, that kind of broke down the different populations. But basically, really wanting to focus on as many people as we can, but particularly for those individuals who rely on us in many cases every day for the services and supports that are necessary. As I mentioned, we've increased our staffing, both by contract and otherwise, within our eligibility team. We have added additional clinical professionals to help us with our medical reviews, so that way, as people, we heard Melissa talking a little bit about kind of the two-part process that occurs when somebody applies or when somebody has come up for renewal in our programs. A lot of it, there is the financial and there is the medical, so making sure we've got adequate support for both. We also are increasing the capacity within our team that does independent assessments, as we know that over the last couple of years, some folks have continued to go through that process. Others, for various reasons, have not had an independent assessment, during that time frame. And so we want to make sure we've got the capacity necessary to be able to get those done quickly and efficiently. We have also begun the process of adding additional support for our appeals and hearings team. That way we know as people may have questions or may want to reach out with regard to questions around their the decision pertaining to their eligibility, that we have adequate support to be able to work through those processes as well. And this is the last couple. We've also, and this is something we did before the pandemic, but we will be using, and many of you have probably already seen some of our pre-populated renewal forms. Those have become available, as well as aligning our appeals process across the various programs. And we can certainly talk about that more in detail, but basically with regard to that long-term service and supports population, making sure that individuals have more time, and that there is an enhanced process for making sure that individuals are able to continue coverage if they want to do so during that appeals process. All right. A little bit more around some of our enhanced operations. We are putting in place a number of new reporting and monitoring systems to give us as live as we can insight into what's happening every day as we're going through this transition process. And so as part of that, we have for some folks, the daily meetings, which we will continue doing throughout the transition, but for others, several times a day meetings to make sure that we are keeping up with what's going on and figuring out ways that we can get feedback and better improve the process as necessary. We are also extending our call center hours, beginning with the call center that is making and receiving updates to contact information. And then over time, we anticipate extending out other call center hours as we officially begin the transition process. And then the last section on this slide really kind of talks about what can we do to make sure that when there is an error, right, whether it's an error that has been made with regard to the application, or in terms of, for example, if information was turned in and it was not entered properly, what we can do to make sure that when we have those situations, we can clearly get it to somebody who can act on it at that time. And so we've put in place an escalation process, so that way if somebody calls and reaches out to our call center, as an example, we can go ahead and get them escalated to somebody who can help them figure out what is the issue, get that addressed, and then make those changes to that individual's coverage as quickly as possible. All right, and now we're going to talk about some of the individual specific programs and give some more detail with regard to some of the outreach and transition efforts that I have highlighted. And we're going to begin with Jay Hill, who is the director of our Division of Aging, Adult, and Behavioral Health Services. So Jay, I will turn it over to you to talk about our choices.
I think is it afternoon? It may be afternoon yet. Good afternoon. Thank you for having us today. And I want to say, too, as we go through this process, so much, the folks at DHS have worked so hard. Mary Franklin and her outfit over at County Operations are really wonderful to work with. And as we work with them and work with our beneficiaries, I think we've understood that communication is key. Communication with our beneficiaries is key to make sure that everybody who's receiving services that may have been extended, that we maintain those services, that we're able to continue, there's a continuation of those services once we exit the PHE, the public health emergency. And so, as I mentioned, communication, if you see, initially our intentions are, and our plan is to begin partnering with our providers to educate our beneficiaries, our clients, about the need for them to update their contact information and to respond to their renewal requests. Our division has begun notifying these agencies. We are already talking with all of our partners and working with them to begin pushing the word out. And as Dawn mentioned, AFMC has been calling. I know that to be fact. Last week we had 2 calls from beneficiaries on AR Choices that wanted to know, is that real? Somebody called me. They're reaching out, and so it's working. It's working. We are talking and we're communicating with those that receive services. And so, following the presentation from our providers that notice is coming, please be prepared. Be aware that you're going to be getting a notice in the mail. You're going to be getting communication from the Department of Human Services. And if you do like we do in our house very often, those things go in the trash. When I get something, that looks like it may be a routine letter, it very often gets thrown away. We want our beneficiaries to know to please look for this. Be aware, be ready, and don't discard the communication that you get, but because it is going to be very important. It's going to tell you that you need to update your information. You need to begin this renewal process. And in our division, we're very fortunate. We have a beneficiary support unit that we are going to be utilizing really in tandem with our field staff. And so for our beneficiaries on our choices, we have registered nurses that work in our field. We have about 60 nurses that cover our state, and they have a relationship with all of our beneficiaries, all of those individuals that are on our program. And so in conjunction, as I said, in tandem with our beneficiary support unit, we will begin reaching out to clients, and what we will be doing is using those nurses that work in the field that have those personal relationships with those beneficiaries to be that contact, that point of contact. And so as we go through our list of all those individuals that we need to reach out to, all those persons that we need to make contact with, while my beneficiary support unit in the central office will create a master list, which we will be tracking and monitoring every day for movement. All of those persons who would be at risk for losing eligibility, we've got to see movement. We have to understand and make sure that we are communicating and that we're receiving back from them what we need. We will be communicating to those individual nurses who, those beneficiaries that are on their caseload, they'll be communicating and they'll be talking. So there will be a person that they know that can help them. Hey, you've got bank statements that are due. There may be a financial piece on your eligibility. There may be a question. We need to get those back in. Or for our beneficiaries that may not have the ability to do that without assistance, our staff also know who their families are, because very often they work with them hand in hand during the process, during the eligibility process to begin with. And so that partnership with those families everything that we can do to make sure that nobody drops from this program inadvertently or by accident or unnecessarily. So it really is a great piece, a component, again, as I said, it's communication with our beneficiary support team in our office, with our field staff, and a daily monitoring, a daily checklist that we will be going over until we reach the end of the process, and everybody has been accounted for. I'll make sure I didn't miss anything. As Director Staley said, unless somebody has dropped from our program, for instance, they may have admitted to a nursing home. If there are persons that need to have their eligibility updated, then our intent is to see that every person is taken care of. We will also be fielding calls internally at DHS, and my beneficiary support team will work as a liaison with county operations just to be able to communicate back to our beneficiaries. Very often you may have a question may come, did they even get my paperwork? Did it arrive? Well, those are simple questions that we will follow up on to be able to communicate back to the beneficiaries, to those recipients of services that, yes, your paperwork arrived. It may be something as simple as that, but to give them assurances that the process is working and that we are working with them and for them. So really, as I said, I think everybody's excited to exit the public health emergency. It's going to be a lift to get there, but at the end of the day, we want to make sure that we continue taking care of our people and our programs.
All right.
I'm sorry.
I'll let you take your notes. Thank you. All right, next up is our kids A and B, and I think Elizabeth Pittman, who is our Director of the Division of Medical Services, is going to come and talk to us about that program.
Good afternoon, everyone. I do want to take a minute to introduce David Jones, who is the acting deputy director for DMS and is our point person for the public health emergency, what we call Unwind. So I'm going to go ahead and run through these bullets quickly, David, but if they have questions that you can answer later. So Division of Medical Services is in charge of helping lead the Our Kids A and B Unwind. Our Kids A is our traditional Medicaid program for children. Our Kids B is an expansion program where we cover children at a higher income level, and they do pay small copays under that program. You may be familiar with it. So we are sharing lists of the clients in both Our Kids A and Our Kids B with their PCPs. You know, kids see pediatricians every year before going to school when they get sick for their well child visits on a regular schedule. So we feel like that's a really good touch point for children. So we're sharing those lists of the children who have been extended with those PCPs so that they can work with those families and let them know that you will lose coverage if you don't work with DHS to get that renewed. It could be as simple as getting an address updated. It could be working through a renewal packet. We also have regular provider meetings with pediatricians and with other providers that we're going to continue. And during those meetings, we'll share toolkits with them that they can use to talk to their patients and their clients about renewing and the importance of that. We also enroll almost every child in Arkansas Medicaid into a dental managed care program. That's how most Medicaid clients receive dental services. A lot of times clients will open mail from those companies before they'll open mail from DHS just because they know that they have dental coverage through Delta Dental, and so they know what that's about. So we are asking that those dental managed care companies help us reach out to families and to children. We're also asking that our non-emergency transportation providers help us by posting signs on the vans and getting that message out to clients because, again, all Medicaid clients, pretty much almost all, have access to non-emergency transportation. We are conducting a paid advertising campaign. We've started that now. We've started advertising the importance of updating your address information. We had a pretty cute one, thank you, Gavin, that played off the May the 4th. May the 4th be with you. So asking people to go and change their address. So we are starting that right now. We will continue that, and we do have some targeted at our kids. And then we are also asking that child care providers, we're going to work with the Division of Child Care and Early Childhood Education. They license child care centers, work with them to help get that message out to parents whose children may be in those facilities. And then we are also, through the communications office and through Medicaid, offering grants to community-based organizations. These are small grants that allow them to do some community activities, maybe have a lunch and a program to talk about the importance of a renewal and getting your updated contact information. Maybe it's hiring a part-time staff person that can help with that. So they can use those grants in a lot of different ways, but we are also working on that. And then I think I'm next. Dawn, so do you just want me to keep going? Okay. Similar to our kids, our home population, which is our adult expansion population, they receive services through qualified health plans primarily. We have a few on fee-for-service, but the majority of those are in a qualified health plan, which is a private insurance company, and that's how they receive their coverage. So we have worked with those QHPs, that's what they're called. It's Blue Cross Blue Shield and Centene. We've already worked with them to share information about who is extended and who is not. They are going to help us with messaging to those clients about the importance of getting those renewal packets in so they can maintain their coverage. They're also working on some strategic plans with us around how to do that. We are asking, again, the non-emergency transportation providers in this space to help us with getting the message out about the importance of renewals. It's a small portion of clients who use our home or with our home that use non-emergency transportation services, but we find that the ones that do are those that have the highest level of need and they're utilizing the most services. So it's very important that they continue to have coverage. So we are going to use those net transportation providers to try to message to them. Same ad campaign will be targeting our home members, so we're doing a paid ad campaign there as well. And the same CBO organizations, community-based organizations. So a lot of this is the same as the Our Kids A and B because this is both a population where we don't have a lot of touch points within DHS or a different division. So we're trying some other ways to get to them using ad campaigns, using community-based organizations. And then we are looking at whether or not the Arkansas Insurance Department would be a good way to get the message out about alternative ways to receive coverage if your Medicaid does not continue, if you're determined not to be eligible for Medicaid, you can go out to the federal exchange. There are some other ways you can get coverage. So just providing that to them. I think it is somebody else now.
All right, thank you. Thank you, Elizabeth and David. So we're going to talk a little bit about the autism waiver, the community employment supports waiver, and TEFRA. And I know we've heard quite a bit from Melissa this morning, but she's going to come and talk to us as well about some of the other things that we're doing, particularly with regard to the autism and TEFRA waivers, but also our CES clients. So, Melissa?
Thank you, ma'am. So, kind of sounded like my boss was tired of hearing me speak.
Not at all.
I'm going to be brief because everybody wants to eat lunch. Okay, so for the three populations that DDS is in charge of for PHE, so what we are planning on doing is we know that DHS sends a lot of mail, and oftentimes it's a lot, and maybe it doesn't all get opened. So what we're planning on doing is sending out a postcard. So we're going to be sending out two. But the first one, we're going to strategically plan it 2 months before a client is going to receive their renewal packet and ask, here's the AFMC phone number, here's the ways you can update your contact information. Please, please, please make sure your address is correct and your phone number is correct so that we can get in touch with you. And then we're going to collaborate. In addition to the postcard, the first postcard, we're going to ask our community providers and nonprofits. We have a lot of partners in this arena to put up posters with information. This worked really well for us in the past when we were trying to implement the independent assessment process. And then we'll be sending out a second informational postcard 1 month prior that is specific to the eligibility category. So what you need to send in to renew your TEFRA application, which is going to include medical information, financial information. And I think one of the things that we're going to hit home on, which lots of people don't know, is the financial has to be very recent. So when we reach out for financials, it has to be the month prior. So, and I think that causes us a lot of time when we get aged financial information having to go back. So we're going to try to really hit that home on the postcard. And so we'll be doing strategic postcards for CES waiver, eligibility, autism waiver, and TEFRA. And then once the renewal packet comes out, then if you didn't turn it back in, then I'll be calling you 45 days later asking why not. So we think that this will be a good method to make sure you've got your postcards, you've got your packet, you need to send it in, because we really don't want any client with intellectual disability or developmental disabilities to lose coverage because we're sending it to an incorrect address or we don't have a good phone number for you. So we are trying to kind of do a bunch of different avenues to make sure y'all are getting our mail, understanding what's needed, and then reaching out to help you if clients don't understand. So, thanks.
Thank you, Melissa. Appreciate y'all bearing with us. We've got just a couple more. We're going to have Elizabeth come back up and talk about past behavioral health.
Hello again. So DMS has the behavioral health piece of PASS. Melissa is working with her clients that are in PASS companies that are on the CES waiver. We're going to be working with Jay and the Division of Adult Aging and Behavioral Health Services to reach those clients that are on the behavioral health side. So there's two pieces to PASS eligibility, as you probably know if you're involved in that program at all. There's the independent assessment piece, and then there's your Medicaid eligibility piece. So we've got to work through both of those pieces. So we are going to work with Optum, who is the vendor that does the independent assessment. Right now, they make 3 calls to a client, and then they put them in sort of a holding status, in that if the client calls them, they can schedule an assessment, they'll get that going. But they're not actively trying to schedule that client anymore after those 3 calls. We're telling them that's not enough, so we're asking them to cycle those clients back through, even if they don't reach them in those 3 calls. We are going to use every effort to have clients who are in Tier 1. So we are who have been assessed in the past 2 years and assessed to a Tier 1. So a Tier 1 is not eligible to receive PASS services. So for whatever reason, when they did that assessment at some point during that time, they were not eligible. Things could have changed, very similar to being on the wait list for so long, and then it comes around. Things can change. So we want to reach back out to those clients and say, hey, right now it's showing you're not eligible, but if you think you are, if something has changed in your life and you want to have assessment, please do so. So we're going to cross that list to those clients who have not received services in the past 6 months. Those who have not would be the ones that would probably come off first. Those who are, we really want to find and make sure they're getting an assessment, because it looks like they probably do still need some services, and we need to make sure that they get reassessed. So that's going to be sort of effort 1. We're also going to work with care coordinators for the PASSes to get their members to update addresses and schedule independent assessments. Care coordinators are supposed to be making monthly contacts with clients. As they do those monthly contacts, they can go through this with them. Is your address up to date? Let's make sure. This is the number we can call. Have you scheduled an independent assessment? Do you want to do that right now? I'll help you do it. So, we think that's a great way to get to getting those independent assessments scheduled. We are also going to send a postcard to each client letting them know what they need to do to keep coverage, whether it's schedule an independent assessment or whether it's get some information to their county office so that they can get their renewal. And we'll outline that for them in a postcard. Similar to what Jay and Melissa both went through with outreach, we are going to train a group to do outreach, so they'll start doing those calls that they went through. We're just touching base. Have you submitted this? Do you need some help? And help them with that. We do have a dedicated unit within DMS to help with PASS in general. It's the Ombudsman's Office. They are going to help us work with the PASSes to target the most at-risk clients, those with the highest level of tiers, those using the most services. So I told you we want to get those Tier 1 people we know are using services. We also want to make sure that are in those high-level tiers that are using daily day-hab services or living in a facility remain in PASS. So we're going to target them as well. And we're going to work with the PASSes and with the providers. So if an individual is in an ICF, or a behavioral health ICF, so we have a lot of children in inpatient facilities. If we know they're there, if we know an adult is in a therapeutic community, we can go to that provider and do those assessments on site and just try to get everyone there that day. So we're working with them as well. And then we're also exploring ways to make independent assessments easier. I don't know if this will be left in permanently, so I'd love some feedback on that at some point. But we are looking at using telephones to conduct independent assessments so that the assessor doesn't have to have a video camera or doesn't have to be there in person. We're also looking at allowing for what we call a desk review or a case review. It's where someone looks at the case and says, it doesn't look like anything has really changed since the last assessment, so we don't think another one is warranted. And then we can take them off that list to be called by Optum. So we're exploring that, particularly through getting us through the public health emergency unwind phase, but also looking at whether or not those are things that would work permanently. Thank you.
Thank you, Elizabeth. And just want to hit on that last point that you heard Elizabeth mention. That is one of the things that we're doing today, particularly with the Our Home client population, where many. Excuse me. Thank you. Our Choice. Thank you. Yes. Too many programs and acronyms. But with AR Choices, in terms of individuals may have noticed that they're not having to go through a full assessment every year, and so we have put in place a process where we do that initial evaluation and determine if a full-blown assessment is warranted. And so we think that that has been working well, though definitely love folks' feedback on that, and that's something we want to try to look at for some of our other populations as well. All right, in skilled nursing facilities, we are going to have Martina Smith from the Division of Provider Services and Quality Assurance come up. Martina was not able to be at the last meeting, but you may remember Tammy, who was with her, as well as Sarah Schmidt. So with that, Martina, I'll turn it over to you.
Thank you. Hi. So our division licenses and inspects and surveys long-term facilities across the state of Arkansas, including the skilled nursing facilities. So we have relationships with provider organizations, associations, and providers across the state. So we will be leveraging those relationships to work with this particular population. So what we've already done is we've reached out to a provider association and we've provided them a list of facilities that have residents in them that may need to go through that renewal process. So that was our first step. So next what we will do is we will reach out to those providers and we will send them an email letting them know our records reflect that these particular individuals are in your facility and it's possible that they need to go through the renewal process. So if they tell us that they are still in the facility, we'll work with them to make sure that the renewal process is completed. However, we know there will be situations where those individuals are no longer in those facilities. Perhaps they've transitioned to another facility. Perhaps maybe they were at the facility for rehab and now they've been able to go home. So we will also reach out and work with other divisions across DHS to ensure that we are able to reach those people now that they are no longer in the facilities. After we send that email, next we'll start calling facilities. I know everyone does not open their emails. We may have some employees that have moved on that the email was going to. So we want to make sure we call the facilities and speak personally with them. We will also set up a provider call with all of the providers for these facilities and answer questions that they may have to help with this process. We have already created an email address so that we can email back and forth with the different providers and we can answer questions that they may have during this process. And then we also have a resource center in our division, and that resource center is a line that we have where people can call and ask questions about the various programs, for example, the self-direction program or the respite care program. So we will be using that resource center line as well to answer questions about the public health emergency and unwinding for skilled nursing facilities.
Martina. All right. And next up we have assisted living facilities and PACE. We're going to have Jay Hill come up and talk a little bit about what y'all are doing on, nope, actually, yes, Jay, y'all are doing that one too.
Thank you. So for our two facility-based programs with the assisted living waiver that we have, as well as our PACE program, our program for all-inclusive care for the elderly, we are partnering and working with the assisted living associations to reach out to the facilities to let them know which facilities they have in their associations that will have beneficiaries that may lose eligibility without some action, without completing the process, so that they can go ahead and put those facilities on point, as well as we've talked to our PACE providers to let them know to begin encouraging their beneficiaries or their participants in their programs to be on the lookout for the information that will be coming to them in the mail. And then we will be following that with a secured email to specific facilities with those names list of those residents that live there that need to complete the process. The same will follow suit for our PACE programs. We have 3 PACE providers to work with them to let them know who it is in your programs that you need to be working with and communicating to and encouraging them to complete the process, get their paperwork back in. And then, as I mentioned earlier, our beneficiary support unit that I have here in the central office will be monitoring this group of people, and we'll be tracking them along with those that are in our AR Choices program for completion, so that we can follow up, and if it's not happening, if there doesn't appear to be movement, that we can reach out and make a second effort and encourage completion of the documentation so that we can keep everybody in these programs.
Thank you, Jay. All right. First, want to say thank you so much for bearing with us. Clearly, we need to work on condensing our presentation a little bit, and I say that as the person who took the longest in the opening part of our discussion. I want to pause for a second for logistics. Jason, do we need to go ahead and start bringing out lunch, or while we go through questions?
What do you think? Do you want to eat and ask questions at the same time, or should we wrap up the Q&A and then have lunch? Any thoughts on that?
We're fine either way, so. Okay.
All right, so who has the first question? Amanda?
So first I want to say, this sounds like you guys have put so much thought into all this, and I want y'all to know that I really appreciate that, and I can see where you're going and all the steps that you're doing. What worries me is, unless I'm reading this wrong, and if I am, please explain, but Act 780 of 2021 says you have 180 days to do redeterminations. It's hard to do anything in 180 days. That matters, that's big. So what I'm worried about is that there could be like a rush on y'all. I mean, you're going to be under the gun. This is really going to be hard to do on your end. But I'm afraid that others are going to get left out. And also, as far as getting people to respond to things, most people, if you had some experiences too long with Medicaid, you're gun shy. You don't want to answer emails. You don't want to fill out forms, and you don't want to answer calls. I've been doing this for 22 years as a mom of a child with autism who's now an adult with autism, and I cringe when I see the pass number come up. Because just for the emotional thing, it's very traumatizing to have to go through and explain everything. And if you are in this position, you know it's exhausting, and re-traumatize yourself. Plus, once somebody has something, like if they have been added to the insurance program in the meantime, they're not going to be looking to give that up. Nobody really likes to let go of what they have. So I'm wondering what kind of carrots you're going to dangle to get people to be more receptive. Thank you.
Absolutely. First, let me say thanks so much for the question and for your feedback. And yes, we have been working on this for some time. I think, as we've even talked about yesterday, even if the federal government comes out and says it's going to be extended further, we are planning to utilize this time to basically start the effort, not actually doing the renewals, but at least trying to reach out, trying to get information updated, because it is a lot. We have been trying to be mindful, and we will share the information with you as it's ready, of how do we think about the different populations and the numbers and the volume in terms of like when these different activities occur, both because we don't want to have it where suddenly we've got a lot of people that are expecting to send back something and then us not be ready to accept that information. So that's definitely one of the things that we're trying to work through. In terms of thinking about the timing, we are able to start some of these activities in advance, including the renewals. So once we actually do get the information from the federal government that the public health emergency is ending, we actually will be able to start that process a month before. So we think that will help in terms of being able to start processing the changes. We have also, as we heard from Elizabeth and others, working with the qualified health plans and the passes to say, hey, we're telling you what we're doing and getting feedback on that, but we also need y'all to be actively engaged in this process and thinking about what kinds of incentives that they can do, thinking about how are there ways that we can simplify this process. And I would say, I think definitely, today and even after today, if there are thoughts on, yes, if you're having to give us that same information 5 different times in the course of a phone call or over the course of a month or whatever it is, we want to figure out what we can do better to be able to help with that. So, certainly, we'll continue to think on that. But as others, as you have additional feedback, as others do, we definitely want to figure out how we can minimize that, because we know it is a lot of work and can definitely be, as you said, I think it can definitely be traumatizing having to go through that over and over again. But thank you. I really do appreciate that. And I do want to call out, we have a couple folks that are going to have to leave us to head over to a meeting at the Capitol, but they will have others here who can help get feedback, but also try to address some of the specific questions that come up.
Okay, I have a question. I think the grant, working with local organizations, that's a really great idea. But is the selection process already complete for organizations? And also, if it's not, how do we ensure that we're reaching communities with the highest health disparities, BIPOC communities, just to make sure the reach and effectiveness? Is there going to be input to make sure that you guys are targeting communities, organizations that are really impacting the community and the people that live in it?
Wonderful question. And we have not begun the process of seeking applications or of awarding those, so definitely perfect timing to get in on that. And we're actually going to be working with our partners here in terms of the Arkansas Foundation for Medical Care to actually go through that application selection and then implementation process. So yes, we're definitely on the front end of that. We are looking to get that application out as quickly as possible, but definitely any thoughts or help that y'all can give us in thinking about how best to outreach as well as to connect into different individual organizations, but also, as you probably saw, if there are groups of organizations or associations that want to come together. We really want to try to do as much outreach as we can, because I think to the points that you heard from several of us today, we know that oftentimes just when we call or send a letter, it may not be as effective as hearing from that person I go to church with or hearing from my neighbor or whomever it may be. So definitely welcome your thoughts and feedback on that.
Medical Care is actually going to be the organization that's going to be handling the grant process.
Yes.
But I guess it will just only be publicized, will it be publicized through the DHS website or their website as well?
As wherever we can publicize it.
Okay.
You mentioned that you're going to be mailing out paperwork. Is there going to be an option for electronic paper? And if so, will there be like a central website for all of these so it's an easier way to find the paperwork?
So, Mary, do you want to talk a little bit about within our eligibility system how you can actually go online and complete that process?
Hi, everybody. I'm Mary Franklin, Director of the Division of County Operations. And we have, within the last year, launched a new eligibility system, but as part of that, we have upgraded the Access Arkansas website. And not only can you apply online now, you can also complete renewals online, you can report changes online, and once you create your own account in the Access Arkansas website, it will give you access to do those things. And you can also opt into electronic messages rather than paper, and you can opt into email and text alerts that we are able to send through the system. I can tell you this, just one special note about TEFRA. In our old system, our old system only had the name of the child on TEFRA. So we are going through a process now, through the renewal process that we have been working on for the last year, to get other information for the other household members, because we need the adults in the case in order for that website to work for TEFRA clients. So if you have experienced that issue or you haven't attempted that yet, if you talk to us ahead of time, we can go ahead and get you added to the case so that you will be able to smoothly do that online process. But yes, we are excited to have all of these new features available for our clients, but we are still available in all the ways we have been available before for clients where the electronic route is not the best route for them. But, and I didn't mention this, but I will now, it is available 24 hours a day, 7 days a week, unless we have it down for typical maintenance period, and there would always be a message if it was down for a maintenance period or if we were doing a new implementation to get new features in the system. And you can upload documents as well. So we are very excited about that, and we do hope that people find it very helpful for those that that's the most convenient way to access our services. And I am one of the people that's going to have to leave you in the next few minutes, but I'm glad I was able to be here this time and got this chance to meet you all.
Thank you, Mary. But
Yeah,
yes,
I have
we'll,
a simple question to help us all get our heads around this. What's going on here? How many people did DHS serve Medicaid to before the public health emergency each year, on average, and how many people are you serving post public health emergency?
certainly.
And I have a follow-up to clarify that.
Great, thank you. So when you look back over the last few years before the public health emergency, we were serving around 1 million Arkansans in terms of through Medicaid. Now, we're about around 1.3 million in terms of, as you saw, we've got about 300,000 that are extended through the public health emergency. But just to give you a sense, like I said, it was about 1 million people that we were serving through Medicaid before the emergency.
Okay, if you were serving 1 million people each year before the public health emergency, and now there's 300,000 that are on it because you can't transition people off. But once the transition starts, previously you may have been, if you do the math, previously you may have been transitioning about 30,000 people a month off. And now you're going to have to do 300,000 a month. This is going to be a nightmare. And you're making transitions to various programs at the same time. Sorry about that. And you're making transitions to various programs at the same time. Your system is going to crash. Okay? People are going to be dropped who have been forced out of housing, because of the pandemic. People are going to be dropped who a lot of things have changed in their lives, that you don't know about. And you don't have a choice because you can't get in contact with them. How are you going to handle this nightmare?
It is a huge undertaking for sure. And I want to say, like with most things in life, nothing is perfect. This won't be perfect either. We are trying to prepare as best as we can. That said, I do want to clarify just a couple things. While the law that we've been discussing did give us just 6 months to do the renewals for the individuals, so for that 300,000, for the rest of the Medicaid population, which also has to go through an annual renewal process, we will have up to 12 months to be able to do the whole population. So I know that that's still a large number of people and a lot of work when we think about that, but I did want to go ahead and clarify that. We are trying to put in place as much as we can with regard to trying to look at what we can do in the system so that when we do identify that there's an issue that may have come up through our escalation team, like we talked about, that we can quickly go ahead and say, stop, right? Let's not make that change. Let's not close that person's coverage if it turns out that there is an issue. Now, we know that, there's a lot of things that we probably haven't thought about, and that's part of us beginning this process is to say, what are we missing and what can we do to help improve this process? And I think, yep. Yes.
So the volume is already being run.
Yes. Yes, that is. Yes, thank you for that. Yes, so as I mentioned, we are one of the states that have continued doing the renewals in the throughout the past couple years, and we've actually been able to renew a significant number of those. Some we haven't, but so our hope is that we will continue to do that in the background, just like we have done over the past couple years, and that in combination with this intensive outreach and communications activity, that we can help get others prepared to go through that process as well. Like I said, it's not going to be easy. It is going to be a challenge for us to get it done, but our hope is that together, for the folks here and for our community partners and others out there, that we can figure out how to do it in the best way possible to make sure that those who need to continue receiving services can remain covered through the program. Yes, you're absolutely right. And I think that's part of why we're also trying to engage providers in this process. I think as you heard from some of the folks here today, many of those efforts have begun, but we also know that there's a lot more that we can do. I think part of what we're hoping is that by giving as many providers as we can their lists of saying, Dr. So-and-so, you have X number of people who you are, taking care of or who you have taken care of at some point over the past 2 years that that could lose coverage. We need your help, right? We need your help, being able to reach them, being able to get their information. And it's going to be an all hands on deck effort. I think and that's why part of the reason why we wanted to go ahead and get the community groups engaged is both to help with that on the ground effort, but also to be able to get more folks signed up so that they can utilize the tools we have available if they want to do it electronically. So it's like I said, it's going to be a significant undertaking, and we're trying to start having these conversations more broadly so we can get that feedback and figure out what we can do better.
All right, we're going to wrap up with 2 more questions, Bradley and Amanda, and then we're going to break for lunch. Bradley?
My concern is about the public health emergency. I have gotten several notices saying that I was cut off from my Medicaid services because of a computer glitch, and I have all the notices here. What's to stop the computer from sending out a bunch of notices saying people have been cut off because of a computer glitch?
Thank you. And Mary, if you don't mind, do you want to talk a little bit about, because we have worked through, unfortunately, some issues where occasionally we do have notices that go out in error, but we've also put in place some additional processes to try to quickly identify those, in addition to doing some ongoing reviews even before we find out that there's an issue. So Mary, do you want to talk about that a little bit?
So I agree with you. That has definitely happened over this last year since we have launched this new eligibility system, a little over a year. Occasionally, something doesn't go quite right and notices go out that shouldn't have gone out. And when
It's one thing to get one, but I've gotten several. Yeah, I've gotten 5 altogether.
You've gotten 5 altogether?
Yeah.
When we identify those issues, we take immediate action to determine what caused it and do what we need to do to get it corrected and send a revised notice out that explains. We have done that. So I definitely hope you got an additional letter that said that your case is not closed or disregard the previous letter, but that has happened occasionally. We do act on it quickly. We correct the situation. We send a corrected notice so that people know if you received a notice that said something was going to happen and it shouldn't have happened, we'll get you that corrected notice in the mail. And our field staff are very good to let us know when they start getting phone calls about something in case it is something that we didn't know had happened. I mean, one thing about having offices all over the state is when they start getting calls about things, they let us know. That's one of the ways we know things that are going on. We partner with AFMC, who helps us with the call center. They also let us know if they start to hear something that's a concern. And of course, our systems team, if they know something has happened, that something went wrong with the batch that was run, they let us know and let us know this is what we're going to do to correct it. This is how we're going to help try and prevent it in the future. So there are going to be mistakes, as you know. They happen. They will still happen. But just know that we will always work to make it right and get it remedied as quickly as possible.
Could you explain to Bradley why he got 5? I mean, you run the renewal every month once it had happened. So, I mean, I think explaining why he's kept getting a notice every month is important.
So I would have to probably go back and do research exactly to find out why you might have gotten 5 different notices.
Part of our problem too is he didn't tell us why. He just said you're ineligible.
What I'm worried about, I wouldn't even brought that up today, but what I'm worried about is with the public health emergency ending, that the computer will do that to people that actually qualify and they won't know what to do.
Well, I can certainly understand that concern, especially since you've gotten more than one notice that was in error. But I can definitely research your particular situation and explain what exactly happened in your case. But just know that we have a large team of folks that work on, first of all, making sure we don't have mistakes, but they happen. I mean, they do happen. Once we realize there's been a mistake, we immediately work to fix it and then get the right information out to people, make sure those cases are reinstated if they shouldn't have been closed, and we will follow up. So continue to reach out if you think something is not right, or if you have a concern about any notice you get, or if you don't understand the notice. We welcome those questions, and it will help us in the future to look at if there are ways we can make the notices more understandable and make corrections.
Are you going to explain? There's the way some of this connects together. I just want to, I appreciate what you're saying very much. And part of what they're trying to think through is, if there is a mistake, what else can we do to catch it and catch it quickly? So we need input around that. Part of what you saw them present was an escalation team that they're going to have. So if somebody got a notice like that, if somebody got a notice that they thought was in error, one, it should, and we've been reviewing the notices, our folks have, so hopefully they say what they should say. I mean, everybody's trying to make sure they do. It'll say, if you think you're eligible, you then can file an appeal. One of the things the escalation team will do is any appeal that is filed, they're going to look at that. Y'all are going to set like a 1 business day, take a quick look. In addition to the appeals operation, there's going to be someone who looks at it that's knowledgeable at a DCO and looks at it and goes, whoa, I think this may have been a mistake. And they'll go ahead and deal with that then, get it corrected, send out word to the client, and then there will never have to be the entire appeal process. Part of the goal of having the efforts that you've heard all of them talking about is so that you can, as she said, call the county office, and if the county office looks and says, oh, there's been a mistake, they can correct it right there. And then on top of that, these efforts where the folks who are on the LTSS programs, there'll be a way for them, they'll also have people they can reach out to and say, what else should I be doing? And that individual can reach into the escalation team. So Director Franklin is trying to have within her operation during the ending of the public health emergency something that is also there that can be a way to take quick action when we see a mistake on an individual case. But then more than that, daily reporting in so that we can make sure, hey, did others get impacted by that? And go fix it. The notices do arrive before someone loses coverage. So that's the other thing. Somebody who has received a notice hopefully will reach out immediately if they think it's been in error. So none of that solves for what you were talking about of we had a system error that did occur, but we're trying to make sure that when something like that does, we're thinking about how do we put something in place to act quickly and make sure no one ends up losing coverage that they should have. So thoughts and ideas y'all have, I mean, I hope you see they're all really open to it, because they don't want someone to accidentally lose coverage who's eligible. So help us with ideas and thoughts. And thank you for bringing that up, because that's incredibly important.
Well, I just know the unwinding is going to be a big undertaking.
All right, last question, Amanda, and then we'll break for lunch.
I had a question about Act 780 again. I am not familiar with this at all. Oh, whoops, I forgot to say on that. I'm sorry. I'm not familiar with it at all. Is it a federal? Okay, it's a state.
It's a state law.
Is that set in stone? You've got to have this done in 6 months, or can there be some pushing out with some extensions and some negotiation?
So the law is very clear that we have 180 days to be able to complete the renewal process. We are working to take advantage of every minute, every second, every hour that we can within that time frame to figure out what we can do early, but also if there are some things that we can do on the back end as well, right? In terms of how we can best work through this transition process. So, we are trying to do what we can to make sure that we are in compliance and maintaining the spirit of the law with regard to what was intended, while also trying to balance. I think from a federal perspective, there is also concerns, right, with regard to making sure we have enough time. So I think we're trying to do as much as we can on the front end, but also then, to the extent there are things that we can do on the back end, I assure you we will do whatever we can to try to make the best use of that time as possible.
All right, thank you, Director Staley, Secretary Gillespie, other division leaders and directors. Thank you for being here, answering the questions. If any of you have questions that we didn't get to you can email them to me, and I will seek out the proper person to provide an answer. But for now, let's break for lunch, and we'll wrap up our meeting and the rest of the agenda after lunch. So one thing that was on the agenda had to do with picking a logo for the council. What I'm going to do is email you the proposed, like the different logos, and we're going to let you rank them through email, the ones you like, the ones you don't like. You can weigh in on them. That's going to save us a little time here in the second half of the meeting. So watch your Medicaid Client Voice Council emails. I'll send you a link to these logos, and this is something kind of that Jerry was talking about. It'd be nice if we could all kind of be working on the same document, weighing in together, which is something we'll work on moving forward. But for now, look for this document, look at the logos, and email me back individually with your opinions, and then we'll try to pick a logo that way. The other thing, there were two other things we were going to talk about in the second half of the meeting, and Allison's going to lead this discussion. One was this report that we shared with you last week. Sick of Waiting was the title of the report, from the Arkansas Community Organizations. We hope you had a chance to review that report, and we just wanted to give you an opportunity to share with the council any ideas in the report that interested you, that you thought were worthy of pursuing, worthy of investigating further on the part of DHS. So let's just open it up. If any of you had some thoughts about any of the ideas presented in that report, we'd like to hear them.
Well, let me just start by, I don't know if we have a copy of that in this week's packet, in this meeting's packet, or if it was only in last time's packet.
I think it was only last month.
Okay. So if anybody doesn't have a copy to kind of look on, if you do have a copy, would you hold it up and then we know who in the room has a copy, and if others need to kind of look on? Most of you have one. Okay, fantastic. Thank you. So essentially, this brief was modeled after a national report that did surveys of people who had applied for various Medicaid programs in several different states, and Arkansas was one of them. But this report is specific to Arkansas Medicaid. And so they did surveys on the phone of these individuals, about
a couple hundred,
about almost 300. Yeah. And what they wanted to know was, what was your experience like in either applying for Medicaid initially or in completing or pursuing renewal? And so if you look at page 4, there's some highlights from the survey. So it says most respondents had a good or relatively easy enrollment experience, but about 4 out of 10 had some challenges when they tried to enroll. People that use the website, mail, and the phone were more likely to have challenges than the people who applied in person. And let's see, 65% of the people who were rejected, so their Medicaid was not approved, reported having problems whenever they tried to enroll. The next bullet, no one answering the phone calls being dropped, not understanding how to apply, feeling stigma or shame in applying, the website being difficult to navigate, not having the forms that they needed, long wait times were the common barriers. And then only 18% of the respondents were dissatisfied with their application experience. 66% were satisfied, and the rest were somewhere in between. And I did look at that national report, and I have to say these numbers for Arkansas are somewhat better, quite a bit better in terms of satisfaction and encountering challenges than in some of the other states. So kudos to the team who works on things here. So that's kind of the essence of what the survey found. But then if you turn over to...
I got page 10.
Thank you. Page 10.
Page 10, they start to share some of their recommendations. They're about 20 or 22 in all, and that's really what we want you to focus on. If any of those recommendations you would like us as a council to encourage DHS to look into or pursue, that's kind of what we're interested in hearing from you.
So some of those under enrollment, staff call centers, online support representatives, and in-person staff, be well trained in the process and in customer service. And as I was reading the report, that was one of the notes that I made was a question for you all is how are the people who are involved in the application and enrollment and renewal process, how are they trained in the technical pieces of that and like who can do what forms are needed, like so that they can answer questions, and then how are they trained as in customer service? And I'm not sure if you can answer that, Jason, or if we need to get somebody to answer that later.
Ruth's still here.
Hi, Ruth.
Ruth Brown is with the Division of County Operations, and if you have questions or recommendations on the report, I visited with Mary Franklin about it, but Ruth has the answers as well. So Ruth, do you want to?
Yes. Hi, how are you all?
It's a mic, yeah.
I'm the Assistant Director of General Operations with Division of County Operations. And as far as customer services, they normally have trainings for our employees, and they basically attend maybe a half a day, sometimes it's a whole day training. And then also in-house, we do a lot of in-house training on customer services. A lot of us been around, I've been around 33 years. And so I myself have done a lot of in-house training. And we normally tell our employees that when a client calls, you need to treat them as if they're your mother, your best friend, and then we know that they're going to answer you correctly. And a lot of times they do find themselves getting a little short. And when we notice that, we do corrective action. So if you notice that the employees are not responding to you correctly, sometimes they don't respond because they don't have the answer. I'm just going to be honest. I've been around a long time, so I'm just going to tell you. Sometimes they do not have the answer because a lot of times when you're talking, when you call, you're speaking with our clerical staff. And sometimes they just don't know what to say. And sometimes they would say, hold on, please, let me get someone else to assist you. So it's a numerous of things that normally happens, but we do try to correct anything that we know that is not correct. As Cindy Ann, Mary, and all the rest of them alluded to, our job is to assist you all in whatever manner we can.
Thank you for that, Ms. Ruth. On that note about customer service, I have one comment as a client, parent. When the last trip that I made into a county office, I guess it's because of COVID, they had put up like plexiglass, between you and the person behind the desk. But unfortunately, that meant that it was hard to hear each other. And so while I sat waiting my turn, I listened to people's personal business being shared very loudly to get through that plexiglass wall. And I felt very bad for many of them. People asking for child care vouchers and being, told, I'm sorry, you're not at the, right place. You didn't bring the right forms, and people being very upset and frustrated about that. And having to do that in front of people is, well, let's just face it. What people are going through if they're walking through your doors, it's hard enough, and they don't need that additional layer of challenge. And I don't know if those plexiglass walls are going to stay up, or if there would be other opportunities to have little phones like they have when you go visit somebody in prison. You see them on the movies, and you pick up the phone, and they're on their side, and you're on yours. Just a thought related to customer service, but I don't want to get us too far down that road, because this is about enrollment and challenges with enrollment, but that definitely can play into that. So other thoughts here, you can see some other suggested recommendations here: creating navigator or assister programs. And we mentioned this earlier with some of the outreach to help with the unwind process, engaging with community organizations that have contact with Medicaid families. And I just wrote down libraries as a good example of somebody who might be a good partner, because they're in so many communities. But y'all just take a look at this entire list, and I'd really like to hear from anybody who's got some specific recommendations here that are speaking to them.
The technology side of me, I guess because I prefer to do things electronically, I would love to see an option where there's an online chat option for parents who are wanting to renew online, and even with that, having someone not only just chat but be able to be on the screen. Because a lot of times we can do most of the application ourselves, but there's just like one question we may want to ask, and if you push a button and someone can pop up and answer that question, that would be completely awesome. I think that would be a great option for parents.
So some live support is what I'm hearing. That's maybe like if you're using that online interface to have a live chat. Okay.
And I think DYS has a chat bot, but I don't think that DCO.
Jason, there's another question over here from Erica.
It's not really a question, but it's a suggestion in regards to partnerships. So I wanted to share, in Southwest Arkansas specifically, we have a 2-year community college. It is the heart of the town. And so maybe partnering with some of those community college, I know that we've got students that did not even know that they had insurance, or whether they do or don't. So maybe hiring a navigator to come and maybe rotate their times at all these different locations. I know that, for example, we have an adult education program. That would be a perfect place to house this person at. And that way we can always have, in my opinion, it's best if you have a go-to person rather than picking up the phone or fill it out electronically, because there's so many questions that come behind or in regards to matters as this. So anyway, I would just like to make that suggestion. Maybe consider also our community colleges or universities, adult ed programs, etc.
Thank you.
Well,
Sandra.
I do have one question. For the navigators in the state of Arkansas, does DHS allow for navigators, or is that like against the rule? Because certain, like, they can't do outreach. Is that appropriate, or is that like a?
You want to step up to the podium, Ruth?
I'm sorry, we do a lot of outreach, and you mentioned the community colleges, not only just the community colleges, but the local, places where else you have a lot of folks that go in and they are feeding them every day, a lot of the local churches. We do a lot of outreach, whereas we do partner with them. So we have a lot of partners. When else they stated this morning that reaches out. It's no way DCO can reach out and to everyone without our partners. So we really rely upon them to do that.
But is there any payments made to navigators through DCO, or is it just as a partnership where they're not being paid, they're just assisting?
It's a partnership. Because we normally, like at the county extension offices, different places like that, we put out flyers, we put out applications, and then they also share with the clients on if they need benefits or whatever they need, they would give that to them. They would give them SNAP benefit application, or they'll give them Medicaid, or whatever it is, because we have now one application for all services. And if they don't need all the services, then they still share that with them. So they do pass out a lot of stuff for us.
I did ask Director Franklin that question when I met with her about this report, and she said that, DHS has a county office in every county where there are people available to assist with filling out forms, but what you're saying is navigators would add to that outreach.
Yeah, like, yeah, exactly what you're saying, because I thought somehow it was like, and I could be wrong, that for enrolling people, like I guess like you're saying, a paid position of navigators going out into the community to enroll people in Medicaid, that wasn't something that was done, aside from maybe you're saying offices of someone who's already facilitated, like if you're coming in here, but nobody's going out searching,
right,
like at a different location.
Right.
And then I guess my other just comment was 90 days for that was a good one for the retroactive coverage. because I think with the Arkansas home, it's reduced now to 30 days. So I know,
What was,
I guess it was the last bullet point. Keep 90 days of retroactive coverage. So I guess when people are applying, and if it's reduced to 30 days, then that could mean 2 months of bills and additional barriers to families who may already have difficulties and challenges with paying for other expenses. So, but that has nothing, you know.
All right, microphone coming to Amanda.
I had several. The first was the create specialized eligibility staff that can help with complex cases. That would be very helpful, I would think. I mean, then I would think it would make it much speedier if you know that you have like self-employed and you can be transferred to that department. The other one that I looked at was accept self-attestment. I feel like that and significantly raise the income eligibility ceiling and asset limits for all eligible groups. You know, there's seasonal work, there's slumps and downturns, and people are just right on the edge, and they have it one month and they don't the next. Maybe if those limits were bumped up a little bit, I know that gets into the money, but it seems like that keeps a lot of people from getting to use the service. And the accepting self-attestment, oh my goodness, that would be, I personally am asking you for that. Like, please, just for me, I don't know. But really, it would be so much better. Just being able to say, yes, this is how it is, without having to do 50 pieces of paper every time.
I want to add one that's maybe related to the Navigator or sister programs, but I know that the way I found out about Tefra was when we needed like a special formula or something, and my child was almost 2 years old, and the nurse said, "Oh, well, your Tefra will pay for that." And I said, "My what?" And I'd never heard of Tefra, didn't know what it was. And she said, "You got to be kidding me, right? Like your child has a chromosomal abnormality and has since birth. You don't know about Tefra? Y'all aren't getting Medicaid?" And I said, no, well, we work. We might not can get it. And she was like, "It's a waiver. Come on, let me take you to the financial counselor." So I wish there was a plan to notify people who are eligible for some of those special programs, at the time of diagnosis. And that could be a policy change, or that could be an outreach initiative, but just want to throw that out there. I think I saw a hand up over here. Where did I see a hand up? Was it Frank? Did you have a? Yeah, okay.
And I just had a comment about the raising the income ceilings and stuff, the asset ceilings and all that, maybe also to kind of keep it relevant, not have to ask for it again later down the road, just maybe find a way to index that to inflation or something.
Well, one question, Ruth, is the asset limit set at the state or at the federal level? Is that something we would even have control of as a state agency?
We don't have control. That is set for us, and then we receive that income limit. And it also changes me as far as your income. As your income fluctuates, and we ask our clients to report when it does, then we have no control of that, because whatever they send us at the beginning of the year, we always get our guidelines to what that limit is. And if your income fluctuates, and sometime it does, you're right there at the limit. I think someone said you just right there. And when I was a caseworker, I have seen people not be eligible for just a few dollars, and it would really bother me, because we all have individuals that are needing these services. But when it comes to those guidelines, we have to hang in there with them and hope that they would change. Let me say that. Yeah.
Thank you. Jerry's got a comment.
Different states have different income limits. If you were in Hawaii, you have a much higher income limit to get Medicaid versus Arkansas or Mississippi or.
I think the question is, who sets that limit? Does the federal government set those different limits for
Just
different states?
the state legislature. usually sets the limits within their states.
But but I think it depends on your state and what everything looks like, the amount of money that each state is giving. And I know we're probably not giving the amount of money.
Oh, it's the legislature.
I'm just saying what Hawaii is giving. They're giving much more money than what we are because the cost of living.
Right. Arkansas State legislators don't give you nothing hardly. You know, it's one of the stingiest states in the country in terms of supporting poor people. But anyway, that's another story. But if you go to Hawaii, they're very generous. You know, but here, you basically have to be on SSI. A lot of people on SSD can't even get into the Medicaid program.
And it depends on which Medicaid program, too. Like Tefra, I assumed I couldn't.
Well, I'm not talking about the program, the waiver programs
right.
or anything like that. They
You're
allow
talking
much higher income standard for waivers. But for basic Medicaid, it's like $700 and some, I think, last time I checked. A month.
I totally agree with you, sir. I mean, our limit is really, really low. And like I said, when I was case manager, there were times when we had someone that really needed the coverage. However, because of the guidelines. So I totally agree with you.
So we as a council have the ability to advise and encourage DHS to make changes in policy, but we can't impact the legislature or the federal government. So we really need to try to gear our, as we look at these recommendations, try to find things in here that we think DHS could implement and that are good ideas. So are there any other ideas in this report that DHS might have the opportunity to implement?
The one that I see that I think is important is being able to coordinate the renewals for all of those programs between the individual that receives either Medicaid waiver, because my family and I, we meet with several different people, and oftentimes it's still for that one specific service, but I'm meeting with a past person, I'm also meeting with a case manager, and I'm like, why can't this be one meeting to coordinate? So I think that would be a great option.
So Ruth can give an update on this, but we have switched, DHS has switched to a new renewal system called ARIES, and they're in the process of moving everyone to ARIES, and that is, ARIES is designed to prevent exactly what you're talking about, the replication, the duplication of forms.
That's awesome.
And so I assume that's, the ARIES is going pretty well?
It's going pretty good. I'm not going to ever say it's 100% because it's a new program and we're still working on it. But that was one of the benefits that we really liked about ARIES, is because in our application, and a lot of the clients say it's long, and it is truly long. But it entails a whole lot of programs, and then once we get that information, we enter it into the system, and it will cover all. So you don't have to keep repeating yourself, and that's a good thing.
That's really nice. Erica's got something.
I'm reading on here where we also say, or where it's being said, allow applicants to upload documents as part of their online application. I personally am able to do that, and I would love that. I think that it's on page, oh, sure. It's on page 10, and it says, one of the suggestions was allow applicants to upload documents as part of their online application. Would that help speed up the process itself if it was done in that manner?
And it is possible. And that's one thing my director, Mary Franklin, she and I work closely together. That's one thing she stated, that you can upload your documents. And yes, what I tell individuals, if you give us everything we ask for, because once they're interviewing you, when you complete your application, let me say it like that, and it asks different questions, and if you're familiar with our process, then you pretty much know what to upload. Yeah. But if you're not, then when you're interviewed and they tell you you need this, this, and that, if you go right to your phone and we tell them take a picture of it and upload it directly to us, it makes the process go back.
I love it. I was just going to make sure and say I love that option.
All right, we've identified some things we could start doing and some things we want to keep doing for sure. What about applications should use plain language and be easy to read and comprehend? How are we doing on that?
Is that available in Spanish or in other languages?
All the applications are available in Spanish.
Okay. And I've got one suggestion in regards to that, because I have people that sometimes reach out to me and they'll say, Erica, can you translate this? I've already translated, but I don't know if it makes sense. And I'll be honest, sometimes it doesn't, because, and I'm sure that's not the process that you guys use, but sometimes they'll do Google Translate. And that's the Spanish that we use in Southwest Arkansas, for example, and I'm sure it's probably the same for Northwest Arkansas. It doesn't read the same. And so I don't know, do y'all have a specific person that just focuses on languages and translating, or is it a system that does it automatically for y'all? I'm just trying to understand.
We have several employees that speak Spanish. And in my unit, especially my client assistant unit, we have a young lady, and there have been clients that will come to the front desk downstairs or downtown, and she goes down and get them, and she set them at her desk, and she goes through the entire thing. We also have contracts with individuals with all languages. So there's no barrier when it comes to the language portion of it, because we can point you to a contract that will be able to assist with that.
That's great.
All right, we're to about 12 minutes left in the meeting, so we can continue on with this questioning, but it will limit our ability to address other issues that council members may have. So I'm open to either.
Let's take these last two if folks would like to offer them, and then let's move on to the next.
Accessibility wise, is it also accessible for visual impairment, the website, or is it no language?
Visual, I know what we basically have done is we have applications that are enlarged, fonts are enlarged, and you should be able to, and I want to make sure I'm clear. Let me go back and check about the system, because I hadn't looked, and I don't want to say something I don't know, but I do know we have applications that are for visually impaired people. But I'm pretty sure online we have a way of increasing that fund, but I want to make sure.
I'm a certified Laubach literacy tutor, and I can tell you Arkansas has one of the lowest literacy rates in the United States. Okay, especially Arkansas, Louisiana, and Mississippi. So we're usually at the bottom 3 of all categories, negative. So having a website doesn't necessarily help people who can't read and write. What do you plan to do to help people who can't even read and write?
Well, for those individuals, we encourage them to ask family members or go into the county office. If they go into a county office and you need to complete an application, what they would do is take you into a room and they would sit there and help you go through your application. They will read it for you. And if you cannot enter it, because we do have individuals that are not computer literate, they will enter the information as you're there, read it, and they'll enter whatever you tell them to enter. So our clerical staff do that all the time. And you are absolutely right. Yes, we have a lot of individuals that cannot. And we do depend upon a lot of families. That's why I really enjoy the electronic piece, because a lot of our family members, the children, other clients live out of state. Well, now they just go online with their parents on the phone and they complete the application from wherever they are. So it's a win-win situation. But yes, there are individuals that can assist with that. And a lot of our partners also assist with that.
Thank you. I'm so glad you're here, Ruth, to help answer some of those questions about what DHS is already doing. All right.
So we wanted to set aside some time in each meeting. There's not going to be a lot of time today. Hopefully next meeting there'll be a little more, just to allow you guys to share with us whatever you're encountering in your worlds, whatever's on your mind that pertains to Medicaid and the Medicaid Client Voice Council. Bradley specifically had contacted us with an issue, so Bradley, if you want to share that issue.
I've already spoken with Cindy Gillespie about it during lunch, but I wanted to inform the council that I had gotten called by Palco 2 or 3 different times, and I always call them back, and they sent me a letter saying that I was non-compliant, that I didn't return their calls, and I have proof on my phone that I did.
Does everyone know what Palco is?
No.
Okay. You want to explain what Palco is, right?
It's supposed to be the payroll agency that assists you. It's like your HR manager.
So when you have someone come assist you in your home, they handle the finances of paying that person. Is that right?
Yes.
Okay.
So with this open discussion, I think it'll be helpful, like, you said you've already kind of logged that request with Director Gillespie, and so she's taken that back to kind of troubleshoot that a little bit more. So as others, if you have things to share, let us know if this is something that you think we should maybe put on a future meeting agenda, or if it's something that you just hope that you're asking Jason to take back to other leaders at DHS.
But I just want you to be aware of that, because I don't know about y'all, but my phone don't always ring. So you can miss calls, and they shouldn't be able to cut you off for missing a phone call.
Right.
I know Jerry doesn't have that problem. Your phone ringing.
Rings just fine. What other?
Yeah, you are.
What other lived experiences are y'all talking? And I shared one earlier just about, privacy in the county offices. And so, if there's opportunity to pass that back up the chain to DHS and maybe for us to make some specific recommendations around that, then I'd love for us to do that.
Are you talking about just in general?
I'm talking about the one county office that I went to where whatever you're saying at the front desk, everybody in the waiting room hears the entire conversation.
Okay, no, but I was talking about like we can share in general.
Oh, yes,
Okay.
yes.
So one specific, and I know it was kind of brought up last meeting, one specific one that I feel that there's a great need for in Southwest Arkansas is we are, our population, Hispanic population is at least half or more Hispanic. And unfortunately, we lost the only person that was actually bilingual in our DHS office. And I think she retired. We're happy for her, but boy, we miss her. I don't know if she's been replaced. Maybe she has. I would really like for this group or for anybody that can hear out my concern, there's a great need for somebody bilingual in that office. I don't know if there's additional funding to hire somebody. I don't think it's necessary for all the counties, obviously. Maybe if we could just focus on those counties with the high percentages. I know Northwest also has a high Latino population, and in general, Marshallese population up Northwest. Southwest Arkansas is geared in that direction as well. So anyway, that's just one of my biggest concerns. For my area, I know that, like I said, the one person that we had is no longer there, and there's a great need for it. So I don't know if there's anything that we could do to help voice that concern.
Please encourage them to make application, because in Southwest Arkansas, I know they have a lot of vacancies because I'm in a meeting with them. And so I know if we have someone that can meet those MQs, it would be wonderful.
And see, I work at we graduate students that I'm sure are more than qualified in those positions. If I'm sitting here and I don't know that there's openings, I don't know if they know that as well.
Is there policy that DHS must provide applications and support in a person's preferred language?
That's why we hired the Spanish interpreters and the Marshallese.
Right, but if there's a policy that's the expectation that's provided, then we have to think beyond filling those open slots. And I think we need to look at things like having contracts with video interpreters in other organizations that can fill those gaps when those exist. Because you can't always just get somebody new in the door.
I understand that, but it's always better to have an in-person.
Ideal, but to fill a gap, we need to think be outside the box.
Yes, no, in the meantime, I think that's a great, but and if I'm being, with all due respect, I think that's patching the problem. I really think that having an in-person there when you're walking in and you need assistance, or maybe just a simple question, somebody that can just even be pulled from the back and say, hey, I'm a caseworker, but I speak your language. I can help you. What is it that I can help you with? That is, it's customer service all around. So I don't know if there's anything that can be done, especially for Southwest Arkansas.
I would say those positions are posted. And then the other thing is the worker positions and the clerical positions are ongoing. So once they make application, if they go out there and just make application for a family service worker or for a program eligibility worker or for a local office assistant, those positions are continuous advertised. So they would be out there. So if anything come open, even if they don't see it, it would pull their name because they're already out there. So if you know someone that's eligible, have them to go and just make application.
Oh, okay.
Yeah, it doesn't have to be for an open position because it's a continuous advertised position.
Okay.
Yeah, and so please
So
encourage.
anybody can apply, and then when y'all have an opening, y'all will go through those applications.
That is what they do is when they make application, then they go in a pool. And as positions are available, then the supervisors go out there and anybody that have applied in their county, then it shows up. And they just pull those applications.
That is good information.
Yeah.
Thank you so much.
You are
All right, we can take one more, and then we need to have our closing remarks and get you guys out of here on time. I know several of you have quite a drive.
Really, I was going to piggyback. Actually, you were speaking in my mind because I work with the Marshallese community in Northwest Arkansas, and they're having trouble with lack of staffing in the DHS office. And I know that one of the organizations there, they help a lot of clients, but again, they're not getting paid like navigators to be helping people, and they also have an organization to help people with other needs. So it's a challenge up there. So I'm really glad that you brought that up.
So anything that you didn't get to share today, write it down so you don't forget it, and we will save more time next time for open discussion. And if there are things that you think should be on our meeting agenda, you can email Jason or Jerry or me, and we'll make sure and that gets on the next meeting agenda or as soon as there is a vacancy.
And just for the point of staffing, I don't know the exact numbers, but I know that prior to the pandemic, we were understaffed as an agency, but not nearly to the extent as we're understaffed now. The pandemic, a lot of people didn't come back to work at DHS. They chose retirement. When it was time to come back to the office, they were still wary of the pandemic, and they just said, I'm done, I'm retiring. And so we have, is it upward of 1,500 positions agency-wide?
For DCO, we have 17. We have 1,700 some positions that we can apply.
So just in the Division of County Operations, there's 1,700 job openings right now. So you may call a county office and no one answers. You may go to a county office and have to wait. And they are doing their best to reach out and find people to work. But I think it was mentioned earlier by Reba, her daughter could make more doing a entry-level, restaurant job is what she's doing now. So part of it's salaries, part of it's the willingness to work. There's a whole lot of issues at play here, and DHS is trying desperately to find help and find solutions. So,
Jason, I think we have DCO have a total of 1,700 positions that we could fill. Currently, we have 100 and some vacancies.
oh, okay.
That's a lot.
Yes, yes, and like he said, we've had a lot of them to retire. A lot.
All right, July 12th, same time, don't know yet about same place, right?
No, it'll be the same place. So
Okay.
the little building down here, they're remodeling. They've decided it's not going to be ready till after the first of the year. So we'll be in this space for the entirety of this year. All right? I appreciate you guys. 52 cents a mile. Leave your sheets that are in your packet here so that it can get processed. Don't take that with you. Just sign it, though. You have to sign it. And it should everything should be filled out. Yes, Jerry?
I can't swear it out. We need to get the complete Microsoft
Yes.
Office.
Some way where we can all communicate.
So we can
Yeah.
have more collaboration,
Yeah.
communication, and participation. Because if I just get an email, even if I have a Word attachment, and I bring it up on my phone, there's nothing I can do with it.
Yeah.
It's practically free.
Yeah.
Microsoft don't.
Yeah, I'll talk to our IT folks at DHS. We got good ones, and they'll.
I worked in IT for 30 years. This is not complicated and it's not expensive. I just don't understand why.
Jerry, you only brought it up 90 minutes ago. Anytime.